Okay, so next up we have the wonderful Emma Crookes, who is a member of the Women's Network alongside many other accolades. So yeah, thank you so much, Emma.
Just sharing my screen. Is it working?
Yeah, it is.
Yeah, real. Thank you. So thank you so much for inviting me today. I'm really looking forward to sharing some of the work that I've been involved in with the RCOG with you. As you can see, I've got quite a lot of roles, but I am just going to stick to a couple of the roles that I've got with the Royal College of Obstetricians and Gynecologists with you today. I'm happy to answer questions at the end about any of them, so yeah, feel free. I'll just apologise as well. I've woken up this morning with a horrific cold that I've got from my kids. Now they're back at school and nursery, so I'm really sorry if I sound a bit funny. So I'm just going to introduce myself properly. So hello, my name is Emma Crookes and I live in Barnsley in South Yorkshire. I've been married to my husband for 3 years and we've got 2 kids, Isaac and Harriet. There's only 11 months between them, so quite close together. Before I had kids, I was a veterinary nurse, so I do have some other experience of supporting births and, you know, just that on my own, but you know, cats and dogs. But at the minute, I am a full-time mum and full-time service user voice. I do work part-time in football security, and I absolutely love boy bands. So, the Royal College of Obstetricians and Gynecologists Women's Network. So, we are the Patient Lay Committee for the college. We're a strategic core college committee, and we champion the best in all aspects of women's health. We ensure that the service user perspective is at the heart of everything that the RCOG does, all the discussions and the decision making. And we want to support doctors, healthcare professionals, students, trainees to be the best that they can be for women and other service users. So all lay members on the committee, we do all have our own personal experiences of using obs and gynae services. We're from all over the country, we're all different ages, and we've all got different experiences. We are supported by a wider network called the Women's Voices Involvement Panel, and that's an online group of over 600 obs and gynae service users, and they bring you know, a real breadth of health experience and to the network, so that we can inform our work and, you know, the activities with the college, you know, more vigorously, I suppose. I've been a member of the Women's Network for about 2.5 years, and I can honestly say it's the best thing that I've ever done. Also on the committee, we've got 4 clinicians. We've got Florence Wilcox, we've got Rona Kearney, Alistair McEvely, and we have, what's the other one? I can't remember. I'll come back to me. Yeah, we've also got a trainee on there, Jen Ellison, and we've also got a vice president as well, and that is Sue Ward at the minute. So as part of our Women's Network role, each member also sits on at least one other core college committee, so that we can bring the service user voice to the table in that committee as well, or Microsoft Teams, as we're all doing at the minute. This list here, it's not an exhaustive list of all of our activities, but I just wanted to sort of illustrate how embedded women's voices are within the college, included in the curriculum for O&G trainees. And as well, a lot of us on the Women's Network, we are lay examiners for the Part 3 clinical assessment of the membership exam. Quite a mouthful. So as part of my Women's Network role, I also sit on the Guidelines Committee. Basically, we help develop the clinical guidelines that are very much evidence-based, and they act as an aid to good practice. I've actually heard them be described by obs and gynae trainees as the Bibles of their obs and gynae training. There's about 70 Greentop guidelines, and at any one time there can be about 35 that are either in production or are being reviewed. Generally, each one gets sort of flagged for review every 3 years, and then the guidelines committee will have a look at it and see if we need to, it needs to be reviewed now, or if we can delay it for 6 months, a year, and that's how it works. So one of the things that I look at when developing guidelines is developers' choice of language. So for me, avoiding negative phrases such as mother failing to progress or poor maternal effort. I think things like prolonged labour, they sound a little bit better. And it's important that we get this language right, during studying, during training, in order to promote, I suppose, a culture change in the patriarchal culture that I think sometimes we hear about and we do see, unfortunately. We've got a bit of a joke on the guidelines committee now about my hatred of the word delivery. Babies aren't delivered, pizzas are. They're born, or women give birth to them. So we do have a little bit of a joke about that now on the committee. So the next slide, there we go. So I would just thought I'd give you a little bit of a summary of the Greentop guidelines process. So it does take just over 3 years to create a brand new guideline. It is a little bit shorter if it is one that's been reviewed, but it does generally follow the same sort of path. At the moment, lay involvement starts when I review the scope and the subsequent drafts, and then this is followed by about 29 months when the document will go out for peer and public review, when absolutely anybody can review it, which then goes back to the developers, and they take those comments into account. Just before coronavirus hit, we were beginning to trial the involvement of a layperson sitting on the development team. So that would mean that there would be lay involvement, right back at the proposal stage, at the scoping stage, every single step there would be a layperson involved with experience. So why involve women in guidelines? I'm not really a fan of this slide because I think there's far too many words on it, but I thought it might be useful, if you want to take a screenshot of it or something, just so that you can see this is the kind of thing that the Women's Network do when we get given, when we get sent, anything at all to review. This is what we're looking at. We couldn't ever understand all the different clinical information that's in every single guideline, but we're not expected to. We're looking at things like informed consent, choice, and just reminding developers that we're not just data. We are real people, and that's equally important. And of course, that word delivery. So the next slide, I thought it might be useful for you if I just whiz through the COVID-19 and pregnancy products from the RCOG, just so that you can sort of get the idea of how this has had to be different to sort of the usual process. So when the Prime Minister announced that pregnant women would be listed as clinically vulnerable during COVID, which was all the way back in March now, the college literally swung into action within a couple of hours, producing version 1 of the guidance, the clinical guidance. Something that we know, would normally take 3 years to go through all those robust procedures. It's become a rapid, iterative process as evidence emerged, as other guidance was released in other countries and from other organisations, and of course the ever-changing situation that we had here in the UK. I can't remember exactly how I became involved in this clinical guidance. It just sort of happened. But somewhere between versions 3 and 4, that was when the Women's Network got involved. When we had a little bit of time, I'm talking an hour and a half that we were given to sort of review it and send back any comments. It was more of a general language check, I suppose, rather than a full-on review. We had about an hour and a half between two of us to review this before we had to get it back to the guidance cell. Which, it was really, really fast. They were working all hours, and we sort of, at that point, we did just have to sort of slot in where we could. Back in April, March, April, May. Then we sort of had a little bit longer to review the clinical guidance. It was about 12 to 16 hours. I became a key stakeholder from version 5, which meant that, you know, as the last step before publishing, it would be sent to me, as well as probably half a dozen other clinical stakeholders for review. But yeah, we didn't have very long at all. It was literally overnight. Now, as that process has slowed down, we do get a few days. There's not been a review for about 6 weeks now anyway, but yeah, it has slowed down a lot. So the guidance cell, which is made up of the RCOG president, so Eddie Morris, the vice presidents, obstetric fellows, some other senior clinicians, and a lot of college staff. There is so many different people that are involved in it. And then there's reps from the RCM, Royal College of Peds and Child Health, and also some reps from obstetric and Anaesthetist Association as well. But it's the RCOG that have taken the lead on this, and they also manage a dedicated email inbox where anybody can send any questions or comments about the latest version. And they do, you know, get back to people, and they take any comments or, you know, anything that they point out into consideration, and that is fed into the next iteration. There hasn't been any time, understandably, for gold standard peer review, but the Guidelines Committee has done 2 reviews of the clinical guidance now. Now it's slowed down. At the minute, we're on version 11. So that, you know, we've got there in like 4 or 5 months, you know, which again, it would normally take 3 years per version to get there. The guidance has now started to be shaped so that it looks a little bit more like a typical Greentop guideline. And to be honest, I can't praise or thank the guidance cell enough for all the work that they've done on this, and how much they've valued the Women's Network's input into this. It's been amazing. There's also quite a substantial list of other guidance that we've been involved in. And there's a little list at the bottom. We've reviewed statements, we've looked at social media campaigns, absolutely everything, you know, on a daily basis and a weekly basis. Now things have started to slow down. So the information that's for women and families, which is the RCOG patient information product, it looks a lot different to a typical patient information leaflet from the college. But the principle's the same. It's based on the clinical guidance. Again, Women's Network involvement first occurred at about version 3, and it's always been reviewed by at least 2 members at a time. At the beginning, again, we didn't have very long to do this, and it was often late at night. The first version that we looked at were 9 pages long, and at one point it were well over 40, so you can see how far it's come. Due to some of my other work that I do outside of the Women's Network and the RCOG, I've got really good networks with maternity service user groups. So it also made sense for me to chair a small group of external stakeholders to try and offer another layer of lay involvement into that, which again, the guidance cell found incredibly useful, and they were really responsive to that. To put things into perspective, I've probably spent well over 250 hours over the last 6 months, often at a drop of a hat, working on the college COVID products. I've made many changes to include appropriate and sensitive and woman-centred language, promoting the importance of choice, personalisation, and I actually reworked the structure of the early pregnancy and abortion patient information products to ensure that they weren't ambiguous. They were a little bit hidden on the website, and we sort of pointed that out, and we were really well supported to make those changes happen. So this is what they look like. So the purple one is the clinical information, and the one on the right, that's the information for women and families on the website. It's just a web page. It's quite plain because it had to be. easy to update at the drop of a hat. And, you know, if it was, you know, unfortunately, we didn't have time to do any fancy infographics or anything like that, because things were changing, you know, day by day, and you know, we wanted something easy to update, and we thought that was really important. So now I'm going to talk about the impacts of the coronavirus pandemic on maternity experiences. I hope that whistle stop tour has been helpful, and just to see, you know, how things have been working throughout the pandemic. So next slide. So having a baby, you'll all know this, having a baby is one of the single biggest moments in a family's life. And coronavirus has basically come in, you know, this year like a wrecking ball. But pregnant women and families have still needed just as much care, if not more actually, than before the pandemic. We need to remember that a lot has been asked of women and the families over the last 6 months. And yeah, we just need to remember that, I think. Many women and families, you know, they do feel really sorry for staff, and they do understand all the added pressures that they're under due to coronavirus. I know we've just heard about that. But I think sometimes I've seen from women that they've got a sense of being a burden to an already stretched system, a stretched service. And it's even been suggested that some women have been grateful for any care that they've received, because at least they've received something. Even when it's not perhaps been up to the usual standards. You know, we're all having to deal with a new way of life, you know, women and families, that's what they're having to deal with. And, you know, not only the typical struggles and anxieties that people have around pregnancy, but as well the extra issues that COVID's brought to that, you know, to the pregnancy, to the birth, and all around maternity care. A global pandemic isn't something I don't think that any of us ever thought about, you know, this year, and especially all these women and families that were planning their pregnancies, and all those managers as well in hospitals that are responsible for organising services. You know, I don't think any of that was, you know, had not been considered in a million years. So moving on to the next slide, I'm going to talk about some of the positives that we've seen over the last 5-6 months. So collaboration, working together, and co-production, other buzzwords. So we've seen how that's worked with the joining up of the RCOG and RCM, with the rapid and iterative production of the clinical guidance and the information for women and families. Again, something that would normally take 3 years to create per version. It's been really positive to see that some trusts have been strengthening their collaborative work by continuing and, in a lot of cases, increasing the partnership working that they've got with local service user-led groups, such as funded, well-supported maternity voices partnerships, and they're sometimes known as maternity services liaison committees. If anybody hasn't heard of these organisations, I urge you to make contact with one in your hospital, you know, especially if you are interested in obstetrics. There's a website called nationalmaternityvoices.org.uk where you can find details about, I think there's over 110 maternity voices partnerships now. And these all came to life from the 2016 report, Better Birth, after the National Maternity Review, which was led by Baroness Cumberledge. As another side note, there is a yearly conference, just in case you don't know, in Manchester. It's normally in March. Next year will be Better Birth 5 years on, where maternity staff and service users come together to share learning and celebrate, you know, what's changed, what's positively changed over the last year. Obviously, I'm not sure what next year's will look like with COVID and, you know, that hitting. But if this is something that you can make it to, I really would encourage you to attend. It's free, you don't have to pay to go, but tickets do get booked up really fast, and they normally sort of get released around Christmas. There's never, I don't think I've ever seen or heard that there's been any students there or any trainees. And obstetricians are normally quite low on the ground that are there, but it would be absolutely amazing, you know, if any of you can make it, that'd be brilliant. Anyway, aside from that, there is a real benefit in involving women's voices, family voices in local decisions, especially when escalating the response to COVID. and approaching service modifications, and especially co-producing communications, and I suppose more recently as things have started to restore and recover. It's absolutely vital that women and families remain at the centre of every decision to ensure safe and personalised care. And this sort of leads on to information. So these are two examples of communications that were co-produced for local women from Bedfordshire hospitals. By midwives, obstetricians, HOMs and DOMs, so heads of midwifery and directors of midwifery, working in partnership with service users. You know, this is the kind of thing that we can do, and this is what women have wanted and needed. So with communications like this, families, they feel informed, they feel in control of their care, empowered, kept up to date, respected, valued, and involved in their local service interruptions and suspensions and changes, and that is really, really important. Good communication and information that's regularly updated and includes timescales of, you know, reconsiderations, you know, and the most important thing I think is fully disclosed reasonings behind these modifications. It means that trusting relationships can be maintained and that there's a real open conversation, and it makes the world a difference, especially when the service user voice is involved in that. You know, if women, I mean, I'll just give you an example. I went to gynecology last week and I walked past the sonography department and there was a sign on the door and it said no partners beyond this point. But I think, you know, if that was, you know, changed to say, you know, unfortunately partners, you know, cannot come into sonography due to lack of space because social distancing would be difficult, that's a different message to you're not allowed in here. And I think that's something that women and, you know, birth partners, that they've really appreciated, and I think it helps with the understanding. Supporting women and families in their pregnancies and births is something that you'll probably do every day if you do train to be an obstetrician. And for many women, it's been a really long road to get to their booking appointment, that first scan, having their bump measured for the first time, seeing a midwife for the first time, and going to antenatal classes, all things that, you know, I definitely took for granted when I had my pregnancies. So I'm going to move on now to innovations and see, you know, how we can sort of try and keep some kind of sense of normality. So I get to talk about one of my favourite things here, which is football, but unfortunately this is not my team. So Covid-19 has meant that we've all had to change how we would usually do the simplest of things. Even remembering to take a mask at shop now, you know, that's something that I think we're all getting used to now. And this has brought really big challenges to maternity services. Even in the case of a global pandemic, the system, the maternity system, it still has to safely and respectfully be fit for women and the families. And it shouldn't be that a woman's care is depersonalised to fit this system. It's really important that we do try and maintain that. So I think an outside the box approach, you know, I think is very well received by service user voices and of course women in the families. It's almost been like a mini transformation programme in some areas. You know, we've seen children's centres and GP surgeries, you know, closed or being out of bounds. We've seen that women and families are, you know, extremely anxious about attending hospitals for routine appointments. And obviously we know that, you know, we've tried to avoid that as well. In the Midlands, this is where we talk about football, they've been using a couple of, over the summer anyway, they were using a couple of stagnant football stadiums for routine antenatal and postnatal clinics to not only keep the midwives out of the hospital, but to keep pregnant women, you know, in a safer place. In London, we've seen that midwives and breastfeeding support workers have been meeting women in parks. If things have not involved an examination, the offer of an examination or screening. A lot of worries, I think, as well have come from women around staff wearing PPE in hospitals. Some trusts release videos or posters detailing, you know, this is what PPE will look like when you come into hospital. But this picture here of Florence Wilcott, Women's Network member, she's going a step further, and it makes all the difference to women and families' experiences. We all naturally remember the bad bits, I suppose, of our experiences, and it can be quite scary when you first see somebody, you know, head to toe in PPE. But just by putting a little picture on her face shield and a name, I think, you know, it's something that women can look back on and turn it into something good, because they're not as worried it is the doctor that they've seen, you know, previously throughout their pregnancy, before COVID hit. And a lot of women have said that once they have seen the PPE, you know, whether that be on a poster or once they have actually seen it in action, I suppose, that they're not as scared about attending hospital. And I think that's really reassuring. There's been so many difficulties facing birth partners, dads, partners, other parents, supportive people, and some trusts have been innovatively using restaurant pager buzzer systems, a bit like when you go to TGI Fridays, for scans, to call in, you know, accompanying companions right at the last minute, so that they don't miss out on seeing their baby, and, you know, like we've heard already, to support the woman. That is, you know, the main thing, to being there to support women, but also, especially if it's the dad, a partner, or another parent, this is their baby as well, and they want to be there to see that. There's been increased anxieties as well, obviously, which is equated to women, I suppose, wanting to see their healthcare professional more, that they need more advice, they need more reassurance. Even though in reality, these have had to be reduced. Again, as we've heard, 6 face-to-face contacts as a minimum, which they're all in sort of the third trimester anyway. Well, most of them are in the third trimester. So many trusts set up dedicated COVID maternity phone lines or social media pages that was, you know, manned by an e-midwife, with a messaging service, and that meant that there was an increased opportunity for women to engage with a healthcare professional in their local area. We do have to note that obviously this doesn't work for all women. You know, those that don't have access to the internet or a smartphone. But it's a great start, and I think that's what we all appreciate. So now I'm going to talk about some of the more challenging parts that we've seen of the maternity experience during COVID, and look at some opportunities that we've got. We know that COVID has brought its own issues to maternity services, but I think one thing that I've seen is that it's also highlighted and amplified a lot of issues that were already there before the pandemic, and that perhaps just weren't given as much consideration. They weren't seen as being important. So as you know, we have begun to recover and restore, it's really important that these issues don't get left behind again. So we'll move on. So dads and partners and other parents, other supportive people. So I'm going to talk about them, and women and birthing people attending appointments, more specifically scans on their own. So I did this presentation a couple of months ago to the members and fellows of the RCOG, and I asked them a question. So I'm going to ask you a question, and it's just something for you to think about. So if you've carried a baby, did you have to attend any scans on your own? If you did, how did you feel about that? Or how did it feel having your partner or other supportive companion with you? And then if you are a dad or a partner or another parent, how did you feel attending a scan with the pregnant woman? Did you receive good news or bad news? And if you didn't attend the scan, like, how did you feel about that? Like, how did that make you feel? Well, I have attended a scan on my own before, and it was absolutely horrific. It was awful. I've just got to say, it wasn't in the case of COVID, but again, this highlights that this area for improvement, you know, was there in more usual times as well. I don't count myself as being socioeconomically disadvantaged or vulnerable, and I don't think any healthcare professional would either. But the bottom line is, when I walked into that scan room on my own, I was disadvantaged and I was vulnerable, and I was alone. And so was my husband, who was helpless outside the scan room. He wasn't allowed to come in because obviously our kids were really close together, and babies, other children, they weren't allowed into the scan rooms. Even though he was asleep in his pram, he wasn't allowed to go in, so my husband had to stay outside. And it was helpless as well. And I just can't imagine how it feels to be in the early stages of labour. And being on your own during COVID, it's such an unknown road, and the impact on mental health, bonding, the whole family unit, I think it's been in jeopardy. And what's going to be the result of this? How much is it going to cost the NHS? And we need to work together now to, try and implement these things, especially now the NHS has lifted visitor restrictions, and we've obviously got the framework from the NHS to safely reintroduce visitors to maternity services. That's something that we really need to look at. At the moment, it is still a postcode lottery as to whether a woman has to attend the scans alone, with no definitive end date for this in England. Dads and partners and other supportive people, they're still not allowed some routine and specialist appointments. They're missing out on visiting their newborn babies, and I use that word visiting very loosely. A parent of a newborn baby, you don't visit your baby in hospital. It's your baby, you want to see your baby, you're not visiting it. And I think if you are ever involved in service planning, please do consider the whole family unit when you're doing so. I am really worried about the lasting long-term effects on family. I've got friends that have had babies during COVID, and I can see that firsthand as well. Considering how you communicate limitations around issues is also vitally important, and the service user voice can, of course, help with this, and that's what me and the Women's Network have done with the RCOG throughout all of this, and it's what we keep doing as well. The bottom line is, I suppose, is that women and families, they don't understand now how they can go to a pub, they can go to Primark, they can go to IKEA, get your nails done, go to a theme park, but they still have to be alone during some of the most emotional and physically demanding times of their life, and they see restoration happening in some places, not theirs. And understandably, they become infuriated. I think, we're at that point now where that's how women are feeling, women and families are feeling. And it goes back to the importance of collaboration and clear, empathetic communication and information, and looking at what innovations you can do. I think that's really important. So, virtual appointments. So, on paper, I think, during the pandemic, this looks like a really great idea, and the solution to a lot of issues that have been facing, that have been happening because the face-to-face care can't happen as much as it can. But yeah, I think a good 6 months in now, we have seen that continuity of carer has taken a massive hit. I've heard from women that they've got no idea who will be phoning them. Will it be their midwife? Will it be someone from their team? Will it be somebody that they've never met before and probably will never meet again? And sometimes they don't even know if these calls are going to happen. Like, they'll be given you'll be called between such and such and 2 and 4, but they're not actually sure if it's going to happen when they've got to 4 o'clock and no one's phoned them. And they don't want to be seen as, being a pain, ringing back, is this happening? I think women can appreciate the stress that, the service has been under. There's still been no consideration or opportunity or time for dads, partners and other parents, and there's been many reports that virtual appointments often feel really rushed, too short and quite impersonal. But again, if you don't know the person on the other end of the phone, it probably is going to feel like that. Important information is also being missed in, at times, because by the time you've got, your pleasantries out of the way, you've established that you can both hear each other, and you've talked about, the general COVID issues that's affecting your local area at that time, that there isn't then much time left to discuss things such as birth choices, group B strep, pelvic floor exercises, and what local postnatal support is available in that area. And also lack of continuity of care means that there's an assumption that those conversations have happened, or it's not that person's responsibility because this is not, this is not their woman that they would normally see. And women, we just can't bear the burden of this. Women, unfortunately, there's a lot of things that you don't know, especially if it's your first pregnancy, and we can't be responsible for that. We can't ask what we don't know. Of course, the flip side of this is that we've come on years with regards to technology and maternity. Some innovations have included online virtual tours of birthing centres and online antenatal classes. But again, unfortunately, many women did miss out on this provision, especially at the beginning of the pandemic. But we are seeing that there are still gaps now. And it's something that we need to make sure that we do cover for, if this happens again next year or whenever. It's something that's really important. Women have not only been suffering without their wider family, but they haven't been able to make them support groups with other pregnant families that are around their gestation. And that's really important, as well as, again, especially if you're a first-time parent. On top of that, the other side of it is that virtual attendance doesn't always work for some women. And I'm not just talking about vulnerable women, but women who perhaps live in rural areas where phone signal might be really rubbish. And we really need to consider this. And I think if you do get involved in service planning and organisation, if one family in your area, if their needs are not being met, then we just need to remember that that's one too many. And it's not a one size fits all, and at times we do have to make exceptions, or again, think outside the box again, to make sure that it works for everybody. So moving on to one of my last slides now. So I just want to share some of my thoughts about the disparities that are facing Black, Asian and minority ethnic women using maternity services. We know that Black women are 5 times more likely to die during pregnancy than white women, but reiterating this information on its own, it's anxiety inducing. And many have described it, I've heard many women describe it as scaremongering. Every single interaction with a woman is important, and it's everybody's responsibility. It can't just be, the onus can't just be put on the woman to make sure that she's socially distancing and washing her hands and things. It's about actually what are the healthcare professionals in her local area, what are they doing to keep her safe as well? Are they making it a priority for her to have face-to-face appointments and ensuring continuity of care? Again, that is key as well. We need to talk about as well why Black women are more likely to die during pregnancy and birth than white women, and we need to actually communicate what is being done because of this statistic. These are real women that we're talking about. They're not just numbers, and it's really important that we're not just talking about race, that we are talking about cultural differences and language barriers, and that it's not just about skin colour. We need to not group Black, Asian and minority ethnic women or BAME women together, because this is such a diverse demographic, and we need to care for each woman as an individual, assessing her own personal needs. That's really important. And as well, we all need to look at our own presumptions and ignorances and what impact these will have on others, and not just their experience but their outcomes as well. We all need to look at that. We also know that the survey issues of voice is stronger than ever, especially after the Baroness Cumberledge report titled Births Do No Harm, which was back in July about mesh. And the survey issues of voice, it can be used to change the clinical power dynamic, balancing it with these women that have got real experience and knowledge of these disparities. So one of these images on this slide, it's from the Royal College of Obstetricians and Gynecologists International Women's Day, which was just before lockdown. And the title of that was Let's Talk About Race. So people's biases and disparities and inequalities, they do remain on the agenda of the RCOG and the Women's Network, and that's in spite of COVID. And, you know, I'm well aware I'm sat here as a white woman, and I'm saying this in a privileged position. You know, I've been given the opportunity to speak to you all today, and I am able to sit on the Women's Network. But, you know, I do pledge to you that, you know, these conversations, they will remain on the agenda. They do remain on the agenda, and it is something that we're all taking really seriously. So I just want to say thank you. I've been really excited about being here today to speak to you all, and, you know, it's just a shame that we can't be in person, you know, because I'd love for all of you to speak to me as well and tell me about you. But I hope that throughout, like, this presentation, I've demonstrated that, you know, we, and I mean students, trainees, healthcare professionals, lay people, managers, commissioners, that we are all better working together with one voice. I think that's, you know, I think that's evident. I hope that you can all take something away from this webinar today, and obviously my presentation. And I'd really encourage each of you to make contact with a local service user voice group in your area or wherever you're working, doing your placements, and find out about how diverse local voices have been involved or not involved during COVID, and the strategies in that area. And I think the other thing that I'd just like to ask you is that when you next have a team meeting or a huddle on your placements, or you do some group work at university, you know, just share something that you've heard here today. You know, I think that's another thing that, you know, the whole patient and public involvement, it's just about sharing and having the knowledge of all these different organisations that there are. The Women's Network, you know, we're really, really, you know, chuffed that we've been in contact with your organisation and some of your members. We're really pleased about that. So yeah, just thank you for everything that you're doing, and I wish you all well in your training and your studies, and I'm happy to answer any questions that you've got, unless we've run over. I do talk a lot, it's the northerner in me. So yeah, thank you.
Perfect. Thank you so much. That was really, really interesting, and definitely a perspective that I'm sure lots of us have never heard before, really, unfortunately. So the most upvoted question, I think you've already mostly covered, but just in case you have anything else to add, how can medical students get involved in the Women's Network?
In the Women's Network. So we do have a YouTube channel, which I'd urge you all to have a look at. There's quite a few videos on there already. Obviously, with COVID, we've not been able to all get to the college, because I know there were plans to film some other ones. So yeah, have a look at our YouTube channel. We do have a general inbox as well. So if you did want to, you know, find out anything specific about the Women's Network, I think it's womensvoices@rcog.org.uk, but I can double check that. It's on the RCOG website. If you do any more events like this, you know, I'm sure there'd be one of us that'd be free to come and speak again. If you do get opportunity to attend any events at the college, there's always somebody there from the Women's Network. We all love going to all these events to meet lots of different people. So yeah, just hunt us down, and we're all on Twitter as well, so you'll probably be able to find us on Twitter.
Perfect. So the next most popular question is, how are the guidelines available to mothers and families, accessible to those who don't speak English or struggle with literacy skills?
Yeah, this was something really big that obviously had come up at the college. As I said, the reason that it is just a web page on the RCOG website is because it's easy to update when, you know, things were changing daily. And obviously this has slowed down now, but every now and again I think we do get a bit of a curveball about, you know, lifting visiting and things like that. The NHS, they did create, I think it was about April time, they did an animation which is also supported by British Sign Language, and also available in the 10 most commonly spoke languages in England. And it's basically the top line messages of the clinical guidance and the information for families. I've not looked at it recently, but it is still there. There is a dedicated NHS page, and you know that was something that they took on. That was something that they had the resources to do. So yeah, that's available. It is the top line messages, and they did say, the college did say that if anybody you know that did speak a different language, they wanted to translate it into a language that they knew, you know, the college would fully support that, but it would be that person's responsibility to make sure it was always up to date. But yeah, the NHS did do the animation, and yeah, it is available in other languages and British Sign Language as well.
Wonderful. And the next one is, what do you think we can do as healthcare professionals to reduce the feeling of burden that women may have when accessing care?
I think listening to them. I think this is one thing, you know, and not rushing them, you know, making sure that you're introducing yourself properly. I think that makes the world a difference, and that's one reason why I always tell people that I like boy bands, because I think it helps people to remember me. But yeah, just taking that time with them, you know, and actually listening to what they're saying, making sure that, you know, not only do they understand what you're saying to them, you know, about any clinical options that they've got, but also, you know, clarify that you know what they're saying to you. I think that goes a long way.
Okay, and so someone said, I think what you said about challenges being opportunities is great. What do you think of the ongoing priorities for obs and gynae care that should be addressed?
Oh, wow. So I think, do you mean like in the sense of women's network, like what we'd see as a priority, or do you mean like me, or?
I mean, the person didn't address that in the question,
Okay.
but whichever you think is
Whatever I
most
think.
appropriate.
So I think for me, obviously I'm involved in quite a lot of things, and I think there's a lot of missed opportunities. I've suffered from a lot of things because of my pregnancies, and it's things that embarrassingly, you know, I didn't know anything about. Pelvic health, for example. So I suffered from urinary stress incontinence during my first pregnancy from severe pregnancy sickness, and it was something that I kept hidden. I didn't tell anybody. I was really embarrassed about it. And when, you know, the health visitor said to me, oh, are you doing your pelvic floor? While she was looking down and ticking the box that she'd asked me, I just said, yeah, when actually I didn't really know lots about it. I didn't know that, you know, I didn't have to be laid down on the floor doing it. I mean, who's got time to lay down on the floor and do that when you've got a newborn baby? So yeah, I think for me, it's about taking a life course approach to things and making sure that, you know, sex education in schools is done appropriately. You know, not separating boys and girls. I remember it when I was younger, and you know, it was, so you got your little bag with you know, your sanitary towels in, and it were like, don't show the boys, don't tell the boys, and you know, and I think that we're coming a long way now, I think, and I think that's one of the real positives of this, you know, making contact with your organisation, that perhaps that's something that, you know, you could help us with to, you know, support young women and girls more. I think that's got to be a priority. It's got to be a life course approach. It can't just be, you know, when you get pregnant, that then you start talking to people about, you know, their periods or contraception straight after, or pelvic floor. You know, these have got to be things that we introduce earlier, and I think then it'd be seen as more normal to discuss these things, and yeah, using correct words as well. That was one thing that really got me in my own care, you know. My GP would be like, so is everything okay down there? And I think if, you know, a healthcare professional is embarrassed to say the word vagina or vulva, or, you know, I think if they're embarrassed, then I'm going to be embarrassed, and I'm not going to want to talk about it either. So I think just making sure that, you know, we're being truthful about things, and we're being open, but you know, it's got to be discussions a lot earlier than when you get pregnant.
Thank you. As a non-medic, what has struck you the most about how the medical establishment functions? Another quite big question.
Oh.
I suppose there's a lot of stuff that we all take as gospel, that it just happens, no one quite questions it. Have you come across anything that you've just been like, why on earth do you not do this?
I think one of the things is like around consent and like discussions. So you could go to hospital and you might feel like you're in labour, and they'll be like, oh, pop on the bed and we'll have a look. And actually, we should be saying, so we to actually find out, we can examine you. Is that going to be okay? And and sort of saying I suppose the pros and cons of that. That's one thing that I suppose I always look at when I'm going to hospital for anything. Do they actually gain consent, or do they just say pop on bed? And I think it's really important that we get that right, because again, it goes back to good information, to choices. Consent is such a big thing that as lay people, that I think we're looking at. And I think sometimes that's probably a thing that we never thought about. Like, I just took things for gospel. So like when I was pregnant the first time, and all I was ever told is, oh, your sickness will stop when you get to 12 weeks, and then when you get to 16 weeks, and when you get to 20 weeks, and you'll have your baby and you'll be home in 6 hours. And like, none of that happened. And you just think, like, why? Like, you feel like a failure. And I think having these honest conversations with people, it can help manage expectations. And I think also make your lives easier as well, because then you've not got people saying, well, you said that I'd be home within 12 hours, and and that this wouldn't happen. And I think actually telling us truths, like more truths.
So the next one is, considering how rushed the process for developing the COVID/pregnancy guidelines were, is there anything that you think could be improved with them?
I think, like you say, the accessibility, that's got to be the main one. We're all well aware of that, and I know a lot of areas with their Maternity Voices partnership, they did look at it like the one from Bedfordshire hospitals, with the little pictures, symbol, the little key symbolising things, things like that. That's obviously that's probably the main thing, the main, I wouldn't say main issue. I think as well, making it look like a typical RCOG product. I think that's obviously important to, well, I don't know for sure, but I'm presuming that that's important to the college somewhere down the line. But for me, especially the patient information, that's not, there's probably a lot of information in there that the college probably wouldn't put in a typical patient information leaflet. And I think we need to make sure that before that's, this is me speaking now as an individual, we need to make sure that anything that doesn't go into it, we need to make sure that it's addressed elsewhere, such as, can I take my kids to school if I am extremely clinically vulnerable, things like that. I think it's important that those questions are addressed somewhere else, if not in the patient information.
Okay, and the next person says, firstly, thank you so much, Emma. And then they said, do you think that women's services have been some of the first to be eroded during COVID? And I suppose following on from that, the last to be reversed as well.
Yeah, I think so. I mean, a lot of my appointments just got completely cancelled. I've got friends who have told me their experiences. One of my friends, she actually found out she was pregnant, literally as lockdown hit, and she tried to access an abortion. She tried to access that care, and she was told she was put on a waiting list. By the time they got round to her, even though she could have been sent the medication by post, that's what the guidance recommended. She was too far on in her pregnancy to have that, which caused her a lot of distress. She don't mind me telling you about this either, by the way. She has told me I can share this, obviously not a name. And you know, it brought about a lot of conflict with her, and you know, she decided to keep the baby, and you know, she's now really happy about it, but it took her a long time to get to that place. And I think, you know, the question there is not just about, you know, that there was a delay, which meant that obviously she couldn't access medication for abortion care, but also the support and the complete lack of it that she's had, and you know, and now she's you know, further down the line, and you know, the effect that might have on her going forward. I think, yeah, definitely one of the first ones to completely shut down, and one of the last ones to get going again. I mean, again, in my area, they're still not allowing partners to appointments. You can go to a scan, certain scans, I think it is now. I think it might be a 20-week scan. You can take someone with you. But I had an appointment in Gynae last week, and there was me. It was a tiny room as well, much smaller than a scan room. There was me, there was the consultant, there was also a trainee in there, and then 3 nurses, and I just could not understand why I needed 3 nurses. I've never had 3 nurses in there before. You know, 1 would have sufficed, I think. And it's things like that that make me wonder, well, why are they still not letting partners into all scans and all appointments, and you know, when there's this many people in here with me, and I definitely don't need this many people in here with me. It has made me think about that, but obviously, like, that's my personal experience and like in my area. But yeah, I definitely agree. It's been one of women's health in general has been one of the first to. It was one of the first to shut down, and obviously now it's been really slow at getting back going. Yeah.
Okay, and just following on from that specifically, you mentioned that there were a lot of people in your room, and I don't know if it was, I think often a lot of us will experience on placement being introduced as part of the medical team, or with nurses, maybe student nurses being introduced as part of the nursing team. It's not always made entirely clear that you're a student, although we obviously are always meant to declare that we are. Do you think that there should be a more rigorous consenting process for having students present in clinical environments?
Probably. I mean, it's never bothered me. You know, I've always been like, yeah, you know, that's fine. But I think if some of these 3 nurses were perhaps students as well, that would have been, it should have been, you know, sort of brought to my attention, and explained perhaps why there were so many people in there. I mean, to be fair, the consultant did introduce the trainee doctor. He did introduce that lady properly, and you know, explained what she was doing there, and he did ask if I was okay if she'd stayed. But yeah, these 3 nurses were just bobbling like behind me, which were a bit like, oh, what they're doing behind me. But yeah, yeah, probably, yeah. I think it's one of them things that perhaps, you know, some people perhaps think, oh yeah, well, I've got to have them in because, you know, they're learning, but sometimes it might not be what they want, especially, you know, if it is something quite embarrassing, or something that it has taken them a long time to pluck up the courage to go and, you know, actually seek out that help, and now they've got this referral, and you know, they've been to the GP who, you know, they perhaps know quite well, and now they're being referred and they don't know any of these people. I suppose it can be quite embarrassing. I mean, one experience that I had when I first went to the Gynae clinic, it was obviously a clinic that is generally frequented by elderly women, and I went in, sat down, you know, waiting my turn, and a nurse came up to me and said, are you waiting for your grandma? And I was like, no. She was like, oh. And I said, I've got an appointment. And she was like, oh, and her face just dropped. And so, yeah, I think it's about perhaps, you know, thinking about, you know, the people that you've got there, you know, like I said, nobody would probably class me as being vulnerable or disadvantaged, but, the fact is when you're on your own and, you are half naked on a bed, you are vulnerable and you are at a disadvantage. So yeah, I think it's definitely something to be mindful of. As I say, I do practice what I preach, and I love speaking to the trainees that are in there when I do have appointments and things like that. But yeah, I think there are some people that perhaps would choose not to if it was put to them as a choice. Which obviously that's really sad for you and your members and trainees and students. But I think it's also important to think, well, why are they doing that? Is it because they've had a bad experience before? Is it because it took them so long to get here? And maybe think about what you can do when you're qualified. To make sure that doesn't happen, or that a woman doesn't feel like that. Perhaps you could look at it like that, like as something to learn from, not as a negative, like, oh well, I'm not allowing that one. Maybe just perhaps try and think about why. I mean, I got involved in all this, service use of voice, women's network stuff, because I had a really bad experience. My outcomes, on paper were good, but the experience was horrible. And I try not to dwell on that, because I want to turn that into a positive, for my friends that are now having babies or had babies. And I think more importantly for my daughter, like she's only just 3, but I want things to be different for her. I don't want her to go through the things that I've been through. And I think it probably is important to acknowledge that some people have had terrible experiences and outcomes, but I think as the service user voice, I do try not to dwell on that. It is about looking at things as an opportunity rather than as a problem. Looking at what we can do, not what we can't do. Nobody wants feedback, negative feedback. But that's why it's important to work together and try and look at every single thing as an opportunity to improve things, not only for women and the families and patients, but also for you as well, because often I think when changes have been made, healthcare professionals often reflect on it, and they'll say, oh yeah, that's a good idea, and it's perhaps not something that you've thought of before. Whereas like the service user voice can often pick up these things and suggest it, but it is about working together. It's not just about the service user voice always being absolutely 100% correct. It's about working together and working with the service that you've got to make those improvements.
Okay, lovely. Well, I think that's quite a good place to finish, because I know you've been talking for an hour and you're ill, so we'll let you go. But thank you so much. Where can people find you online?
I've got Twitter. I put it on all my slides. But if you've got anything burning, you can contact that website that's for the Women's Voices. That's on the RCOG website. It is on there. If you type in RCOG Women's Network, it does come up. But yeah, if you have any more of these, we'd love to, even if it were just to listen and get to know like your organisation. Like I know I said to you, Molly, like I'd actually not heard of your organisation before, and I think that's a detriment to me that I don't know that you're here. Obviously I do now. I've stopped everything. But I think, yeah, as a service user voice, you often get frustrated when you speak to clinicians, like the real high up people, and they've not heard of Women's Network or Maternity Voices Partnerships or whatever it is. But equally, looking at it like, flipping it on its head, actually, we want to know about your organisations. And I think if, the Women's Network can support anything that you're doing, then I think we'd definitely be happy to help. Well, I would anyway.
Well, thank you so much.
No, thank you. I hope it's
anyone can contact Emma on the details she's given. So yeah, thank you so much.